Hello, everyone, and welcome to Changing Healthcare, Learning from the Success of NICE. My name's Andrew, and I'm part of Kaleidoscope, and we're a social enterprise that brings people together to improve health and care. And I'm joined by my two esteemed panelists. If you'd like to introduce yourselves.
Hello, I'm Tara Lamont. I'm director of the NIHR Dissemination Centre, which tries to make evidence more used and useful for people in the service. And I'm also a member of the HSR UK board, a network for health service researchers.
And hi there, my name's David Haslam. I spent most of my career as a general practitioner, but I was chair of NICE from 2013 to the end of last year, 2019.
So you can see we have two strategically chosen guests. We also have some people in the back room who you can't see who are making this all run smoothly for us. So we've got Peter, who will be operating the technology, Jess, who's taking your questions, and Seren, who is tweeting. Before we move into the content of the webinar, we've just got a few housekeeping items just to make sure that you know as participants how you can get involved. So there are three ways you can ask questions, and we'll be coming to your questions throughout several points in the webinar. You can use the Ask the Question feature, that chat feature on your GoToWebinar platform. You can email us at that email address, hello@kscopehealth.org.uk, and you can tweet using the hashtag #ChangingHealthcare. So please do send in those questions and we will happily come to them during the webinar. So what is today about? Well, it's part of our Changing Healthcare series, which Kaleidoscope and HSR UK are running together, and it's where we're learning from examples of successful change in the NHS. 3 weeks ago, we had our first face-to-face event as part of that series in London, where we looked at what we could learn from the success of NICE for delivering large-scale change. Some of you who've joined us today will have been able to join us at the event, which is great, and you'll be here to carry on the conversation, but some of you won't have been able to join, and that's why you're here, so that you can learn from what we found out on the day. So don't worry, there's plenty to offer whether you were there or not. We'll be sharing some of what we learned in video form, which will be quite exciting, and we'll be inviting you to join the conversation. But you can also join us for our further events in the series, whether or not you came to the NICE event. So we've got 3 more coming up, and these are all free events. So there's How Come We Don't Talk About MRSA, and that's all about learning from the reduction in healthcare associated infections. That's on the 1st of April in Birmingham. Bruce Keogh is one of the speakers, along with several other very expert speakers. On the 12th of May in Bristol, we'll be looking at how day surgery became the norm, and that will be another very exciting event. And then finally, on the 7th of July in Newcastle, we'll be looking at non-medical prescribing. In other words, how did pharmacists and physiotherapists come to prescribe medication? And these are all really interesting examples of successful change. So before we move on to the content of the day, you've heard who you've got as your speakers, but we want to know who you are. So a poll will be coming up now, which will ask you all about how you describe your main role. So as you can see, you've got a few possible options there: research or policy, management, frontline professional, or service user. And apologies that there's no other option, but if you just pick the one that best reflects or is closest to what you do. Okay, and we'll have a look at those results now. Okay, great. So we've got an interesting mix of people then. So roughly equivalent numbers of research and policy people and frontline professionals and management, which is great. We don't have any service users this time, though we did have some at our face-to-face event in NICE, and we do always encourage service users to get involved in these conversations and contribute their valuable perspectives too. Fabulous. So you have made time for this digital event today, which is great. And you've told us why. You've given us some of the questions that you'd like the webinar to answer, and we'll be coming to some of those hopefully later. But to help us get more of a sense of what it is that we can get from this digital event, we thought it would be helpful to hear from some of the people who joined us at the face-to-face event, and we asked them why they made time for that event. So let's hear from them now.
Well,
I've been to other Kaleidoscope events, and they're always really interesting, really stimulating mixture of people, quite engage people quite actively. So I always look forward to Kaleidoscope events. And because I have worked in health and social care for such a long time that I remember the creation of NICE, so I was particularly interested in thinking and talking about its history and evolution and the reasons why it's succeeded for so long.
Well, NICE is an organisation that I come across a lot in my sort of day-to-day role, and a lot of the NICE decisions and the NICE guidelines sort of come into the work that I do on behalf of clients. So I thought it would be a really sensible and interesting event to attend to learn a bit more, so I can then take that back to my organisation.
I've made time for this event today. Well, for two reasons really. The first thing is the content of the day. Really interested in NICE. Don't know a lot about it. I'm relatively new to the world of health. This is my first job in the world of healthcare. So it's a kind of learning, lots of learning for me. And the second thing is that I've been to a Kaleidoscope event before, and I know that it offers loads of opportunity for discussion, reflection. Yeah.
Fabulous. And I promise that we didn't pay those people to say all those great things about Kaleidoscope events. So before we move on, as I said, we will come to the questions that you've asked us, and don't forget to submit your questions as we're going along. Before we talk about the specific learnings that we had from the day, we will hear from Tara now, who was one of our speakers on the day as well, who's going to tell us why we actually chose NICE and what the themes that we chose to talk about. Tara.
So we were looking at initiatives or big changes in healthcare systems, which have improved outcomes and were based on good evidence, or where there was good evidence of the effect through evaluations, and where we think we can extract some sort of wider learning for the service. And so NICE was one of our first choices, really. It's bold, it's much envied and copied in other parts of the world. And interestingly, actually, Nigel Edwards had asked his Twitter followers a few days ago what they thought were the most successful policy and service initiatives in the last 20 years. And again, NICE came up together with perhaps some other obvious candidates, national service frameworks, infection control, endoscopic surgery, smoking ban, some of those topics, as Andrew said, which will be covered by future seminars in this series. But we were really interested in NICE, both how it came to be, but more importantly, how it survived in quite a turbulent 20 years of policy and service changes, and in an age where there's mistrust of experts and a lot of contested decisions about, particularly around high cost treatments. How has it been that NICE has weathered those storms? And we picked out three themes which we wanted to explore further at the face-to-face event and at this webinar, which are the breadth of involvement, the stakeholder engagement that was an important part of NICE, particularly in its guidelines development work from the start, the use of evidence and also robust processes to assess the evidence. And then lastly, the stability of leadership. This is an organisation which over the last 21 years has had extraordinary stability and consistency of leadership, and what can other organisations learn from that?
Great, thank you very much, Tara. So hopefully that gives you a very clear introduction to why we chose NICE as a case study, and clearly it wasn't just one of the ideas that were plucked out of thin air, but that we'd really thought through. So before we move into the first theme, just to remind you again that you can send in your questions. We'll remind you of the three ways you can do that. You can use chat, email, or Twitter, and we look forward to answering those. We've already had a few already, which is great, and do keep them coming in. The first theme of the day, as Tara mentioned, was breadth of involvement. So we'll talk a bit now about what we learned about involving a range of voices, how NICE has done that, and what that means for large-scale change. Before we hear some reflections from our panelists, we'll hear from some of the speakers on the day.
Any large-scale change, the more people that you can get talking about it, discussing different aspects of it, exchanging ideas on it, and trying to get people to understand what change actually means to people is a really good thing. So the more people we talk to about it, the better.
I think what I took from this morning was that we talked about seeking a diversity of voices. And I think if you seek a diversity of voices, you've really got to listen, but you're going to hear some things that you might not want to hear. That's the whole point. So I think it's about having that courage and that humility to hear both people that you wouldn't normally talk to, but also hear things that you perhaps don't want to hear. And that's the real value.
That's a bit more of a difficult question because meaningful is different for every single person. But I think this openness and talking quite honestly about what big scale change is and how people get involved in it is the thing that we've got to do to make it meaningful to every single person.
Great, so those were just a few reflections from our very rich conversations that we had on the day on involving a range of voices. So David, would you like to talk to us a little bit more about that theme of how NICE has involved different voices?
Well, for me, it's almost such an obvious issue that it barely needs discussion. Of whose illness is it anyway? Whose condition is it anyway? It's not the mindset of NICE almost from day one. It's an absolute clarity and recognition that it's the individuals who have to live with conditions or have to live with the consequences of NICE's decisions who have to be involved. And part of that, as Tim Irish said in the Vox Pop there, was stressing the importance that you listen to difficult arguments. You're never going to be able to satisfy everyone. But right from the start, NICE has had a patient and public involvement team, has gone out of its way to recruit people to as much of its work as possible. Pretty well every NICE committee has, we aimed for at least 2 members of the public, 2 patients or public representatives to be involved in the work. NICE's board has included public involvement, and indeed NICE's board meetings are held in public, genuinely in public, traveling around the country. And at the beginning, certainly for my 6 years as chair of NICE, at the beginning of each board meeting, Sir Andrew Dillon and I would take questions and answers from any member of the public who wanted to come along and ask us how we worked, challenge us about our decisions. It's not easy. It's the closest thing for me to being a GP, just not knowing what's coming next. But it just felt really, really important to be open and transparent, because it's not the NHS's problems that we're dealing with, it's patient and public problems that we're dealing with.
That's a really, really powerful challenge and point for us. Thank you, David. I don't know if you had anything you wanted to add, Tara.
Well, I would just say that it's not easy to do it well. And I know in my organisation, you know, we really try to be thoughtful about how to engage people in the right way. And I think I do look to NICE, and I think there's something about recognising that, for instance, in the guidelines development process, what could perhaps be thought of as a technical process of kind of weighing up the evidence is actually a social one in which you're making sense of the evidence, and in the absence of the highest quality evidence, coming to a decision in a very robust and systematic way in which different voices are heard and recognised. So I think that is exemplary, and I think there's something about NICE was quite innovative, I think, in having its Citizens Council. So recognising that there was a social and ethical dimension to some of the decisions that were being made around, rare diseases versus a common illness, and those difficult societal questions, so that they haven't shirked away from those tricky issues. But I think there's something about recognizing the social and deliberative nature of decision making, which I think is really...
No, and I think you're right, Tara. And I think, NICE has always recognised that it's been faced with some of the most difficult issues in public life. And if that's what you're dealing with, it's really important not to be authoritarian, but to be working with the public. It's the only way you're going to get there. The other really important thing was the importance of supporting members of the public, patients who became involved, because they might find themselves on a committee or a board, sitting next to someone with a Nobel Prize in whatever the topic is. And we really stress to the chairs of these committees that everybody is equal, that it's really, really important to bring these different perspectives.
I think that's a really important theme that came up on the day as well, isn't it? And it's a real challenge, as you say, to I think for some people when they're getting involved to feel equal. And so the onus is definitely on the organisation that's involving them to create that space and send that message. We've had a few questions as well on this, which is great. So why don't we start with one of your questions when one of you registered for this digital event, which is great. You said, how well does NICE think it succeeds when it comes to patient and public involvement? David, perhaps you're best placed to give a view on that.
These are always, it's slightly tricky when you're asked to sort of mark your own homework, as it were. But certainly NICE, again, we publish, and NICE publishes regularly reports about the impact that our work has had and the extent to which the patients and public have been involved in the development of the work. So that's very much there. I think the feedback we get is generally very positive. We regularly, NICE does research to just check that it is addressing the issues in a way that people accept. I've found quite often when I met members of the public or patients, they might not be happy with the answer that we came up with, but they were happy with the way that we got there. They really felt that we had taken other views on board. You're never going to satisfy everyone. We're always going to be faced with a healthcare system which has more demand than resources available to pay for it. So there's always going to be difficult issues there. But if you felt to be fair, and that for me was always the test, you might not necessarily like the answer, but I want you to feel we did it fairly.
Thank you, David. And a couple of other kind of practical questions on involvement. So how did NICE how did NICE decide who to involve and when?
Well, as I said earlier, right from the start, this was seen as an integral part of our work. So there are two. Tara mentioned the Citizens Council, in which we are trying to get the viewpoint of a representative group of the British public based around things like age, education, gender, ethnicity, and so on. That is a group of people with probably zero expertise in the topic, but they're trying to represent the public, which is always very difficult. Then there's the issues where there's a particular condition we're looking at, where we will recruit people with a particular interest in that, either as a patient or as a carer. Carers, let's not forget, are equally important in much of this. If you go anywhere near the NICE website, you'll see advertisements for recruiting people to become involved. We're really keen on people to get involved. And it's not just a question of using the usual suspects. There's always a risk in patient and public involvement that you get the professionalized patient representative who moves from one organization to another and ceases to represent the real world.
I think that's a very important challenge. Did you have anything to add on that, Tara?
Not really, no.
Great. Okay, well, thank you so much. That was such a rich and interesting discussion, and hopefully gives you a flavour of what we discussed and the kind of things we discussed at the NICE event itself 3 weeks ago. We'll move on now to the second theme, which is what we learned about using evidence. So we had a session on the role of evidence in a post-truth world, as we called it on the day, if that's not too bleak a theme. And we had speakers, we had James Raftery from the University of Southampton, and then I can't remember the other speaker, can you, Tara? No, we were also lucky enough to be joined by Tara as well, who spoke on the day. As you're here, Tara, I'll let you speak for yourself about how NICE has used evidence, and more broadly, that theme of using evidence in large-scale change. But just before we get to you, we've got just one reflection from Nick Timmins, who was also one of our speakers on the day.
Well, it's relied on evidence. It's assembled a lot of evidence, both for the health technology appraisals it does and for the guidelines, so that when it makes a case for something, it can adduce a lot of evidence in its favour, which is persuasive, and therefore helps people accept the decisions that it then goes forward to produce.
Great. Thank you. Over to you, Tara.
So thinking about NICE and evidence, and this partly kind of addresses a new question that I've just seen that's come up about what are the conditions that enabled NICE to be set up in the first place. And I think there is something about that moment in the late 1990s where there was this confluence of what was starting to be a real kind of groundswell of bottom-up opinion in the medical community around the importance of evidence-based healthcare. So although, you know, some pioneers like, you know, a hero of mine, Archie Cochrane, since the 1970s, had been making the case for the need for trials and robust evidence to really demonstrate the effectiveness of treatments. There was still the issue of a proliferation of guidelines and a sort of dispersal of research evidence, which didn't quite funnel its way into clinical practice in a systematic way. I think I read somewhere that there were, you know, over 60 separate guidelines for the management of asthma, for instance, in the days before NICE. So there was something about the emergence of evidence-based medicine at a time at which there were these hugely controversial decisions about experimental treatment, so and concern about postcode lottery. There was the infamous case about Child B, I think having some experimental bone marrow treatment, where the health authority decided not to fund the treatment, and it was contested that had this child lived somewhere else, they might well have been supported to have the treatment. At the same time, in a way, for the first time, there was a kind of stream of robust, pragmatic, UK-centred trials through the establishment of the Health Technology Assessment Programme and other sort of funding programmes that were very NHS centred, again, just at that time. And as James Raftery reminded us in the seminar, also just coming up to the year 2000 when NICE was established, there was a development in York of a widely accepted tool, the cost per QALY, the quality adjusted life year, which was accepted as kind of standard currency against which the cost effectiveness of drugs and new treatments, the fourth hurdle, could be assessed in a way that was recognised as an acceptable standard. So all these things in a way had to come together with the kind of policy window of a new government with a mandate to modernise public services and with a kind of emphasis on rational decision making. So all these things coming together, I think, meant that NICE was set up with a kind of bedrock of evidence. But importantly, as David's already said, there was something about developing very robust processes for technology appraisal and for guidelines development, whereby the assessment and appraisal of the quality of evidence was an important part of that. So rather than having a rather kind of opaque process where in the past there'd been sort of narrative reviews by a esteemed clinician, but it wouldn't be terribly clear what the strength of evidence was. With the guidelines process, you have an explicit assessment of the evidence, and importantly, as we heard from Nick Timmins, one of the early test cases in NICE was the Relenza episode, which showed not just the ability of NICE in its very first year to take tough and difficult decisions on the basis of evidence, the evidence that was available at the time, saying that it would not be cost effective to fund Relenza, but also an ability to change as new evidence came on board. So I think there is something there, not just about an institution that is very much celebrating evidence and asking people to be critical in their evaluation of evidence, but also having processes so that in the absence of the best quality evidence, there's still a systematic way of making a decision.
No, I agree with every word you say there. I mean, I remember years ago you could get guidelines that the work had probably been sponsored by a pharmaceutical company, and surprise, surprise, the recommendation at the end of the guideline was that you should use that company's product. That isn't a guideline, that's advertising. So internationally, better ways of using evidence in guidelines were developed, particularly using a methodology called the AGREE criteria, which focus on important areas like have you involved patients and the public in the work. And probably one of the ones I got most obsessed about was the question of conflicts of interest. Because if an organization produces a piece of work and then at the end of it, critics say, well, they would have said that, wouldn't they? Look at the people who were involved, then you might as well have not done the work in the first place. You have to be really, really tough on conflicts. And so NICE is constantly re-strengthening its conflict of interest policy to try and make sure that we get this as perfect as possible. I mean, the chairs of our committees now are chosen because they have no particular expertise in the topic that they're looking at. That might sound counterintuitive, but it's actually, they're not bringing a pre-focus. They have expertise in chairing. That's quite different from expertise in the topic. There are then experts in the topic who are there, but the chair ensures that it's done effectively. The other thing I'd say is NICE has to have these really tight criteria for the way it looks at things. It has to be legally challengeable and so on. And so it does develop these protocols that it works to, whilst simultaneously constantly self-criticizing and saying, have we got this right? Because it'd be hopeless to develop a really tough set of criteria and then never move as the evidence moves. And so NICE, I think, managed to combine this sort of toughness and fixed criteria whilst having the flexibility to recognize when it needs to develop.
Great, thank you. Well, there's lots to take away from that discussion, actually, on the use of evidence and the various different processes in place. So thank you so much to you both for sharing that. And thank you also for sending in your questions. Do keep them coming in. So remember, you can email, chat, use chat, or send them in on Twitter. But we've already had lots already, which is great. And I think we've, although we haven't explicitly come to them, I think we've touched on two of the questions that you've asked us about, both the conditions and factors that enabled NICE to establish its position and last as long as it's done, and how NICE deals with those complexities and nuances of evidence to produce clear-cut guidance.
Well, the only thing I'd add to the reason that NICE was set up, and which I think links to why it continued in existence when you look at the other healthcare organisations that were in existence 20 years ago, the vast majority of them have been abolished at least once, and some of them twice. So NICE had a really clear remit, and the two main areas that it was looking at were the health technology assessment, looking at expensive new technologies that might be needed in the health service and determining whether the cost effectiveness justified their introduction, and also the guidelines program. So those are the two main ones. But if NICE wasn't there to make the difficult decisions about, is this expensive drug justified? Is the cost of this drug justified? If they weren't there, somebody else would have to be there. Somebody else would have to make the decision. The decision doesn't go away. And the great benefit to politicians over the years has been, NICE has been there to take the difficult decisions for them. And I was perfectly happy as chair of NICE to effectively be body armor for the Secretary of State. I mean, that might sound a ridiculous way of looking at it, but it felt important. Sensible politicians, and I've talked to many ministers of health around the world, recognize that somebody has to make these decisions, and it's much better that it's based around the criteria, the sort of things we're looking at, rather than being just left to he or she who shouts loudest. Otherwise, you leave these decisions to politicians who are then going to be influenced by lobbyists, and lobbyists are influenced by money and all the rest. So the clarity of what the problem is that the organization is there to solve is vitally important in continued existence and success.
I quite agree. Sorry, just one last thing. I quite agree with that point about the distance from difficult decisions. Thinking about NICE and evidence, I think the only other thing I would say, where we're so lucky in this country actually to have sort of joined up systems in terms of healthcare and research, is that the guideline process can also identify gaps in the evidence and uncertainties where we need to commission new research. And there is a feedback loop to the National Institute for Health Research, which I work for, where we can then directly fund trials or other studies to address those particular uncertainties, which are important sort of decision problems for the service.
Great. Thank you both very much indeed. We'll move on now to our final theme of the day, which is all about structural stability, including stable leadership, its role in NICE's success, and then more broadly in delivering large-scale change and the lessons we can take from that. Before we discuss that, we'll hear from a couple of our speakers on the day who spoke to us about this theme.
We've had a really great session on stability of leadership, and what stayed with me has been the audience and the audience's wide range of questions, enthusiasm and knowledge of what NICE does. I was really quite impressed with their understanding of how we work. I think NICE has done lots of great things over the past 20 years, but underpinning all of that is clarity of purpose. People know that NICE issues guidance for the health and care system, and having clarity of purpose that you communicate well, I think is absolutely essential.
Well, stable leadership has clearly helped, but stable leadership only helps if it's good quality leadership. And I suspect, though I was never been in the room when it's been happening, that one of the reasons NICE worked quite well was it did have a stable leadership, but there are a lot of very bright people who were capable of challenging each other about the decisions they had to take and the way they had to go about taking those decisions. So it wasn't a sort of, a monopoly grey view of the way forward. I think there's a lot of intellectual challenge within the leadership that then produced a stable picture of what they wanted to do and got on with it.
We talked a little bit about stability today, but also I think it's more about the culture. So we talked about how good NICE was at taking evidence and logically working their way through evidence. But I think we also talked about how NICE is very transparent, about how it's very open when it slightly gets it wrong, and about how it has mechanisms such as appeals, so that there's trust in the system that the evidence is being used, and if it's not being used well, there is a way that you can actually recompense for that. So it's the wrapping around the evidence.
So David, I wonder if you can comment on whether NICE has had good quality leadership and bright people in the room.
Far be it for me to comment on that. I mean, I've puzzled a lot about whether NICE was successful because it wasn't reorganized all the time, or whether it wasn't reorganized because it was successful. I mean, you can argue it in both directions. But I actually think Nick Timmins and Tim Irish in those comments there had it spot on. It's that constant questioning. I certainly encourage the non-executive directors on the board to constantly challenge, to ask the difficult questions. And I think having that ethos, which is accepted by everyone, and the executive directors, non-executive directors, everyone working together, constantly questioning, are we doing this in the best possible way? Listening to the responses, the comments that come in. It's not a question of just blocking your ears and saying, no, this is the way we do it. We're the wise ones. It's that listening, but using evidence, as Tara has said so often. That's critically important. Public engagement, we haven't mentioned this much, but engagement with the professionals as well. I think one of the smartest things that Sir Michael Rawlins, my predecessor as chair, did at the startup of NICE was to really involve the medical profession and to ensure that the name of NICE focused on excellence. The letters originally stood for National Institute for Clinical Excellence. Who can be against clinical excellence? I mean, that's, so names matter, focus matters, involvement, engagement, engaging all the people who are going to be involved matters. I think those are the critical issues.
Thanks. Anything to add, Tara?
Well, I just add, I think the cultural values are important, but I do think there's something about the continuity of leadership. I mean, at a time, I don't know what the average lifetime of a trust chief exec is, but it was, like a vanishingly small.
Premier League manager,
yes, yeah. And I think there's something about having confidence to take difficult decisions when the time frame isn't, too short term. I think there's something that other systems and other organisations can learn from. In just it's sort of slightly old-fashioned now. It's like the term planning, but there's something about having stable and high-quality leadership.
Thank you. And I think we've got time for one quick question. So one of you has said, in over NICE's lifetime, there must have been differences in opinion, both internally and with the groups it works with. What has been particularly powerful to help overcome those disagreements or differing opinions? David, I wonder if you have any thoughts on that.
Well, it's listening, isn't it? I mean, it's listening and taking notice. It's not digging your heels in. It's recognizing that if there is a difference of opinion, there must be a reason for that and trying to explore that. It's no different when dealing with groups than it is with dealing with individuals with a disagreement. I've always felt this. So understanding what's really behind this and explaining the challenge. I mean, I always used to feel that when I was being lobbied by people who wanted, for instance, an expensive drug to be made available to their family member, that I could completely understand that. If it was my family, if it was my grandchildren or children, I'd want the entire United Kingdom gross domestic product spent on them. That's not the question. The question is, what are we all prepared to spend on next door's family, or just anybody? And for every time that you spend money in one area unwisely, you're taking it away from another group. So I was always aware, for instance, of people with mental health problems who maybe were not making as much noise about their problems as people with cancer or with some of the tragic conditions that can be faced. And it's recognizing that the organization is there to represent the whole population to try and get the best answer for those. So it's listening, understanding, explaining, the same as in everything else.
Great, thank you very much. Now, we're coming towards the close of this digital event, and one thing I would encourage you who've joined us today to reflect on is how you will use what you've learned today. And while you're reflecting on that, we'll hear from some of the people who attended our face-to-face event about how they would sum up the day and what they've learned.
I think I'd start today as really stimulating. It's been a really stimulating day.
inclusive. Yeah, that's one word. Yeah.
I'd say enriching. I think I've been really taken by some of the discussion around NICE and discussions about stability for good and otherwise, I suppose, the kind of rich discussion about the notion of stability. I think I have, I mean, I've come away with a little reading list, which seems to be a common feature of a Kaleidoscope event. Yeah, and then there were one or two side conversations that I had with other people about not totally unrelated topics, but about other things that are of interest. Yeah.
Well, I work with a lot of different health and care organisations, mainly charities. So I think some of the things we talked about today about the real importance of maintaining clarity of purpose, and this point about how you really draw out lessons, how you draw out what were the really critical success factors so that you can apply them in other situations, but you're not just trying to impose things from the top down. You're still drawing on those as principles, but then trying to enable people to add their own creativity, energy, take on things so that it's not simply imposed, but it's still drawing on and learning from what's been learned elsewhere.
Fabulous. And before I ask Tara and David to offer us some very brief closing reflections, we asked the people who took part in our NICE event one piece of advice they would give to people who couldn't make it on the day, and we'll see what their advice was now. Some great pieces of advice there. Can I invite you, Tara, to give us a 30-second closing reflection on the event?
I think, as well as what it means for local organisations, I'm really interested at a policy level. I think without NICE, you probably wouldn't have something like the Institute of Fiscal Studies, a kind of arm's length respected body, or the What Works centres in education, in well-being, in aging and so on. So I think there's something about how it has stimulated some really a helpful movement of evidence-based decisions centrally as well as locally.
Thank you, Tara. Dave.
Well, listening to the discussion, looking at some of the questions that have come through, it really struck me that it all comes down to values. If you're clear what your value, if you're a leader and you're clear what your values are, if the organization is clear what its values are, and then you can live by those. And by values, I don't mean Californian psychobabble mission statements, which are just designed to irritate. I mean, really, for me, it's to do with patient and public centeredness and excellence and those things. And if you're really clear that that's what you live by, then all the other answers, all the other questions become much more straightforward.
Thank you both very much indeed. And just a reminder, you can come to our 3 remaining events in this series, all of which are free to attend. Well, all that remains for me is to say thank you very much indeed for joining, and thank you so much to our two esteemed panelists for such a rich conversation today. Thanks and have a good afternoon.